16th Augusto D. Litonwa Endowed Lectureship. The Augusto D. Litonwa Endowed Lectureship is held in honor of Dr. Litonwa, a pillar of the Philippine diabetology, a renowned clinician, a much sought-after lecturer, a respected teacher, a keen scientist and researcher. Dr. Litonwa's love and interest in diabetes is manifested in different avenues he has undergone through the years. Postgraduate, clinical and research fellow, Thyroid Clinic Massachusetts General Hospital, and concurrently research fellow, Harvard Medical School. Research fellow, Thorndike Memorial Laboratories, Harvard Medical School, and concurrent resident in diabetes, Boston City Hospital. Visiting scientist, Department of Medicine, University of Washington Medical School. Assigned to Division of Endocrinology, Harborview Medical Center, Seattle. At the University of the Philippines College of Medicine, rose to become professor and chairman, Department of Physiology, clinical professor of medicine and chief of endocrinology at the Makati Medical Center, the longest running director of medical education, chairman of medicine, chief of endocrinology and physician in charge of diabetes educational clinic at Asian Hospital and Medical Center, first chairman of medicine and chief of endocrinology, first chairman of accreditation committee at Diabetes Philippines, put up Diabetes Watch, became its first editor-in-chief, and cited as its emeritus editor, established the first diabetes chapters in several provinces, PDA workshops, permanent office of the association, which stood for several years as the Facility Center, Shaw Boulevard. Societies founded, organized, and become its first head. Philippine Society of Endocrinology, Diabetes and Metabolism. Philippine Association for Study of Overweight and Obesity. Philippine Center for Diabetes Education Foundation Incorporated. ASEAN Diabetes Educators. ASEAN Study Group for Diabetes in Pregnancy. ASEAN Federation of Endocrine Societies. Other positions held: President, Philippine Diabetes Association for 11 years. President, University of the Philippines Alumni Society since 1961. President, ASEAN Federation of Endocrine Societies, 1972. President, Philippine College of Physicians, 1979. Chairman, Philippine Specialty Board of Endocrinology and Metabolism, 3 terms. Chairman, Southeast Asia Study Group for Diabetes. President, Philippine College of Physicians, 1979. Dr. Augusto D. Litonwa has indeed left an indelible mark in the scene of diabetology, not only here in our country, but also internationally, as a recipient of the American Association of Clinical Endocrinologists Award for Most Understanding Endocrinologist Serving an Underserved Population, and was awarded as International Clinician by American College of Endocrinology. That mark has also been left in the hearts of those he has touched, and in his studies, whom he always admonishes to continue to reach for excellence in the care of people with diabetes. A man truly worth honoring. Hence, the Augusto D. Litonwa Endowed Lectureship. The Augusto D. Litonwa Endowed Lectureship aims to deliver updates and showcase the latest findings, trends, and studies in the medical profession. Since its inception in 2007, it has gathered prominent names who are the best of the best in their field to share their knowledge and expertise. Today, the honorary physician diabetologist at the Diabetes Resource Center, Malaysia, is invited to discuss the topic Modern and Classic Approaches in the Management of Type 2 Diabetes Mellitus. He graduated with MBBS from Monash University, Australia. He undertook advanced specialist training courses in diabetes and endocrinology and obtained his postgraduate degrees from UK. He was later awarded the FRC and FRACP. He was Professor of Medicine and Dean, Faculty of Medicine, University Sains Malaysia, and later appointed as Vice President, Research and Health Services at the International Medical University. He was also the Professor of Medicine and Consultant Endocrinologist and Diabetologist at the IMU. He is a member of several national and international professional societies. He was the founder and first president of Malaysian Diabetes Association and Malaysian Endocrine and Metabolic Society. In 2001, he founded the National Diabetes Institute, a non-profit organization managed by a board of trustees comprising representatives from the Malaysian Endocrine and Metabolic Society, Diabetes Malaysia, Ministry of Health, elected and founding members. At present, he is the executive director of NADI. He was a co-founder and past president of ASEAN Federation of Endocrine Societies and chairman of the East Asian Study Group on Diabetes Mellitus, and a founder member of International Diabetes Federation. He is chairman of the Action Against Diabetes in Asia Collaborative Group and the member of the Diabetes Academy to promote diabetes care internationally. As an active diabetes researcher, he has published more than 100 papers and presentations in national and international journals. He is on the editorial board of Pakistan Journal of Medical Sciences, MIMS Asia, Malaysian Journal of Medical Sciences, and is the editor-in-chief for the Journal of ASEAN Endocrine Societies since 1998. Ladies and gentlemen, a warm of applause to the 16th Augusto Dilitonwa Endowed Lecturer, Emeritus Professor Dato Dr. Mustafa Embong.
Good afternoon. Welcome to the 16th Augusto Dilitonwa Endowed Lecture. Our speaker for today is Professor Embong Mustafa, and it is my pleasure to award the ADL Endowed Lecture Medallion to Professor Mustafa.
Thank you very much, Dr. Tommy Welling, for the presentation. I now wear it. Great. Good. Thank you very much, Dr. Tommy Tai Welling, for the kind introduction. I would also like to thank Professor Litan Jua, Diabetes Philippines, and the organizing committee for having me today to share my thoughts on the management of type 2 diabetes. Now, we take note that this session is sponsored by Servier Philippines. Let's start first by looking at what type 2 diabetes is. It is a metabolic disease and characterized by this hyperglycemia, and it is believed that it is because of the disorders in insulin secretion and insulin resistance. The insulin secretion might be manifested by blunted or loss of first phase or the exaggerated phase 2 insulin secretion. Eventually, there is reduced insulin secretion because of beta cell apoptosis. Insulin resistance can be seen in muscle, in the liver, adipose tissue, and pancreas. Now, it is also believed that it is affecting the gut, the kidneys, and the brain. Having said that, let's look at how we usually manage our diabetes. The aim of managing diabetes might start off first by just trying to prevent acute complication and eliminating hyperglycemic symptoms. And eventually, hopefully, we can improve the quality of life and prolong healthy, productive lifespan. But this is a very wide discussion. I'm going to limit the discussion today just looking at preventing microvascular and macrovascular complications using a medication. So our scope of discussion is to look at the management of hyperglycemia to prevent chronic diabetic complication. Now, the microangiopathic complication involving the retina, kidney, the nerves, and the macrovascular complication covering the heart and stroke, for example. We are now going to start looking at diabetes before the 1990s. At this time, drug-wise, management is very easy. For the simple reason, it is easy because there are few drugs as available at that time. We have the insulin, and we have the metformin, the biguanide, and we have the sulfonylureas, first generation, and we have the second generation sulfonylureas. So in this case, we will have insulin to reduce the blood sugar, and there are quite a few of them at that time that's available. We have the biguanides, basically just a metformin to reduce insulin resistance, and we have the sulfonylureas to stimulate beta cell to produce more insulin. Now, there are the first generation sulfonylurea. Some of us will still remember chlorpropamide and torbutamide, diabetes, for example. But many of us might still be using the second generation sulfonylurea, the glipizide, the glabenclamide, the glyburide, and the glyclazide, the micron preparation. We were also told at that time that we should manage our diabetes stepwise, looking at starting off with a diet and exercise, and later on, if there is not well controlled, then we might add in a drug. If it is still not controlled, we add in multiple drugs. Then after that, we will start oral medication, perhaps with insulin, and the last will be the intensification of the insulin therapy. We will also want to treat the comorbidities such as hypertension and dyslipidemia. So, in summarizing, management of type 2 diabetes in the 1990s will be stepwise, starting with step 1, looking at diet and exercise. At this time, we are allowed to wait 3 to 6 months to have the diet and exercise effect before we go into step 2, adding in drugs. For those who are obese, might want to choose metformin. For those who are not obese, might want to consider starting with sulfonylurea. If there is still not control, then the metformin, we will add in the sulfonylurea. For those already on sulfonylurea, we add in the metformin. And if it's still not getting to target, then we would need to add in insulin, either with oral agents or on its own. Now, fast forward, we're now looking at managing type 2 diabetes after the 1990s. And life becomes more complicated then. Why? Because first, we are now asked to manage our patient based on evidence. and the evidence comes from clinical trials. And the landmark clinical trials at that time include the UKPDS, ACCORD, VADT, Advance, and the Advance On. From these studies, we can divide our patient into two groups. The group one are those who are newly diagnosed, early diagnosed diabetics, who have not that bad control, or otherwise are free of complications such as cardiovascular complications, but relatively young. For this group of patients, we can treat early, and we are asked to treat pretty aggressively to achieve the target blood sugar control within 3 to 6 months, and to aim for an HbA1c of less than 7, or better still, less than 6.5. And this is based on the UKPDS and the follow-up studies. In the UKPDS, we see that there is, for every 1% drop in the HbA1c, we can expect a decrease in the risk of microvascular complication of about 40%. There's also a reduction in the any diabetes-related complication and some effect on myocardial infarction and the stroke prevention. More importantly, in terms of the UKBTS, is the legacy effect, where the beneficial effect of early treatment is manifested years after stopping the study. And here we see the slides looking at 1997 when the study was stopped, and 10 years later, we were told that, for example, in microvascular disease prevention, there is a risk reduction still maintained at 24%. In terms of the all-cause mortality, there is indeed an improvement in the risk reduction from 6% to 13%. And recently, we are told in 2022 that this legacy effect is maintained some 30 years after stopping treatment. In terms of microvascular disease, there is a risk reduction still of 25%. In terms of the all-cause mortality, there is still a risk reduction of 11%. Now, we also have the extreme on the other side, the group 2 side, where diabetes is long-standing and the patient is rather poorly controlled, and the presence of complication, especially cardiovascular complication. They are relatively elderly population. Elderly is defined as more than 65 years old, and they are have a short life expectancy because of the comorbidities. For this group of patients, we are asked to treat them less aggressively, maintaining the HbA1c around 7 to 8%, and we asked to achieve the target less urgently, looking at 6 months or so to arrive at the target HbA1c. And of course, we are asked to avoid frequent severe hypos. And this recommendation comes from the ACCORD, the ADT, Advanced and Advanced On studies. The ACCORD study, the one that really gives us a big headache, because the study shows that if we are to treat the diabetes to lower level in terms of HbA1c, and pretty aggressively, we are going to face more deaths. The all-cause mortality, for example, is in excess of about 20%. Worse still, in terms of cardiovascular disease, the excess death is over 30%. But fortunately, the VADT and the advanced on study shows that if we were to treat this patient not aggressively, achieving the level, our target more slowly, using drugs that causes less hypoglycemia, then we might not get this excess mortality. And this is one slide that I can show the advanced on study using dimicron MR, looking at the intensive treatment versus the standard treatment. And we can see here follow-up of over 10 years for death caused by any death from any cause. There is no difference between standard and intensive therapy. And importantly, in terms of cardiovascular death, there is no difference between the intensive and the standard therapy. Now, managing diabetes past 1990 also becomes more complicated because of the many new drugs that's available. And we look at we have more insulin now, but importantly, we have many more oral medication. The alpha glucosidase inhibitor, the glanites, the thiazolidinediones, the DPP4Is, and the SGTI medications. Importantly, we now have an injectable other than insulin, GLP-1 receptor agonist. We can look at post 1990 in terms of the drugs that are now available to us. We have insulin, and there are many more there. Human insulin, analog insulin, the short-acting, the long-acting insulin, perhaps the ultra-long-acting insulin. We have many more oral hypoglycemic agents in addition to the metformin and sulfonylureas that we had. We have the metaglanites, alpha glucosidase, thiazolidinediones, peptidase 4 inhibitor. But as I mentioned, we now have many drugs in the incretin mimetics group, the LP1 receptor agonist, starting from Vita twice daily injection to once daily injection, and now to weekly injections. Because of all the many drugs that is now available, there are many guidelines that came out from many societies. But I'm just going to look at one in terms of the AADA, EASD treatment approach. Now, ADA and EASD suggest that we should divide management into two groups. Tier 1, which is using well-validated therapies, and Tier 2, using less validated therapies. Tier 1 therapies start with step 1 at diagnosis, where we need to start with lifestyle and metformin. Note that at this time, there is no more separation between lifestyle and the addition of metformin. As previously, we are told that we can wait after lifestyle, but not anymore now. If after a lifestyle and metformin that do not work, then we go into step 2. And the step 2 is when we add in a sulfonylurea, or if the patient has very severe symptoms, then we might add in basal insulin. We have the option given at that time to go into tier 2 using less validated therapies at that time. We can use the TZDs, the pioglitazone, for example. We can combine the pioglitazone with sulfonylurea if you want to. We can use GLP-1 agonist. We can use the DPP-4 inhibitor. Sometimes we might want to use the alpha-glucosidase inhibitor. And we also have the option of using basal insulin at that time. If all these are not well controlled yet in terms of our diabetes target, then we might add in insulin. At this stage too, we are asked to be more patient-centric in our approach. This is the concept of individualizing the management. We have to choose drugs which are more suited to the patient, looking at the patient clinical profile in terms of the glycemic status and the comorbidities. We need to look also at the patient preference in terms of cost, in terms of the availability of facilities and drugs, and their lifestyles. And of course, we need to look at the drug efficacy and the adverse effects. These are two examples that we want to look at. Perhaps looking at people with mild, moderate HbA1c who are either normal weight or underweight with minimal symptoms, we might want to choose a sulfonylurea agent as an add-on. For those who are overweight or obese with minimal or moderate symptoms, we have the choice of DPP-4I or the GLP-1. Those who have poor control with marked symptoms, then we have the option of giving insulin. We also have to be cautious about the complications that the patient might have at that time, and that some drugs might be contraindicated using those at that time. For example, in patients with congestive cardiac failure, we might need to avoid thiazolidinedione, especially rosiglitazone, and some people also want not to use metformin in this group of patients. We move on looking at why post-1991 management becomes more complicated. Well, the other issue that we need to face are the better understanding of the pathophysiological defects of type 2 diabetes. I just want to briefly show this slide, shows the classification, sub-classification of type 2 diabetes. I'm not going to go into details of it, but just to emphasize the two extremes of this group. One is the group with severe insulin deficient diabetes, so-called SIDD. In the other end of the spectrum are those with SIRD, severe insulin resistant diabetes. Based on the pathophysiology, we can now treat our patient to the dominant deficiency. If we have insulin deficiency, then we might want to consider using sulfonylurea, insulin, pioglitazone, or even the GLP-1 receptor agonist. If the dominant pathophysiological defect is insulin resistant, then we might choose drugs such as metformin, thiazolidinedione. We now come to the other problem that we face in managing type 2 diabetes post 1990. And this is the era of the CBOTs, the cardiovascular outcome trials. I just want to show these slides to emphasize the many CBOTs that we have. There are a lot more now, and I cannot remember the names of these cardiovascular outcome trials. Basically, this slide shows the blue mark there is the lifting trials, the yellow the GLP-1 trials, and the red are the SGLT2 trials. All these problems started with the SGLT2, the empiric outcome trials. In the empiric outcome trial using empagliflozin, we see a risk reduction of hospitalization due to heart failure. This is about 30% of reduction. This is where the ball starts rolling. And since then, there are many more CBOTs using SGLT2I for cardiovascular protection. Here, looking at the three major ones, the CANA, IMPA, and dapagliflozin, the best result that we could get was the reduction in hospitalization due to heart failure. It's about 30%. There's also a reduction in the all-cause mortality and reduction in the cardiovascular death. People are also looking at the effect of SGLT2I in terms of renal protection. The best result that we see is the progression to end-stage renal disease, which is about 60% risk reduction. There's also a risk reduction in terms of progression of kidney disease, and of course there is a reduction in the composite outcome. Then the GLP-1 receptor agonist comes in, and many CBOTs that comes with that. This is a summary of the class effect of the cardiovascular outcome in relation to GLP-1 receptor agonist. Example, we have about 15% cardiovascular mortality risk. We have reduction in myocardial infarction. We have risk reduction in all-cause mortality, especially in stroke, for example. We also have the effect on heart failure, but this is not very prominent for the GLP-1 receptor agonist, looking at only about 10% risk reduction. People also look at the renal outcome for the GLP-1 receptor agonist, and we do have some effect, about 20% risk reduction. We can summarize all those just to highlight it. The one with the hospitalization due to heart failure, the best result is from SGLT2I with 30% risk reduction. In terms of the ischemic heart disease, myocardial infarction, MACE, we could get about 20% risk reduction with GLP-1 receptor agonist. And we emphasize that a patient with stroke, there is also a risk reduction in stroke, about 16% in the GLP-1 receptor agonist. In terms of the renal outcome studies, the best result is still with the SGLT2I with a risk reduction of about 40 plus to 60% in terms of outcome, progression, as well as progression to end-stage renal disease. GLP-1 receptor agonists do have some effect. They are in the range of about 20%. So if we cannot use SGLT2I, then we have the option of using GLP-1RA for patients with renal disease. Now, what I'm going to show you might scare you a little bit because we are now looking at how we treat type 2 diabetes in 2022. And this is a slide that just came out on the recommendation by EASD and ADA on type 2 diabetes management. I do not want you to worry too much about it. For those who are interested, they can read up the big fat reports on it. I cannot understand myself. But let's just summarize what this is all about. In treating type 2 diabetes in 2022, we need to consider lifestyle adjustments and metformin. That is our first step at diagnosis. Lifestyle adjustments now becomes a bit more elaborate with diet and exercise, looking at not smoking, reducing excess weight, reducing stress, having adequate sleep, and of course, providing education in terms of the diabetes management. If we cannot get to target all those, then we might need to end medication based on the pathophysiological defects in this patient with type 2 diabetes. For those who are insulin deficient, for those who are insulin resistant. Beyond that, now we are asked to check whether the patient has established or at high risk of developing heart failure. If the patient is prone to or has heart failure, then we are asked to add in SGLT2I as part of the treatment. Some people say irrespective of the HbA1c level. For those patients with ischemic heart disease, prone to stroke, we might need to add in the GLP-1 receptor agonist. And for those who have chronic kidney disease, we need to add in SGLT2I or otherwise use the GLP-1 receptor agonist. Now that is about the end of my talk in terms of managing diabetes. What we need to do is perhaps I need to reorientate ourselves to priorities. We know that heart disease is the main cause of death in people with diabetes. We then go back and look at how good is our treatment now in terms of treating heart disease? In terms of heart failure, the best medication that we have is the SGLT2I, and the risk reduction that we saw just now was 30%. We now have about 70% residual risk still present. For ischemic heart disease, MACE, for example, the best result that we could get is the SGLT1 receptor agonist, which risk reductions of about 20%. Still, we have about 80% residual risk that we have not addressed. The question that we might want to ask ourselves is, why? Why are we having this still high residual risk in our patient with diabetes, in spite of all the new drugs that we have? Well, let me just provide you with this work in progress in trying to reduce residual risk. We will start off with possible reasons and perhaps provide some solutions to it. The first possible reason is because we have not been optimizing treating associated risk factors. We now look at cardiovascular disease. We know that hypoglycemia, dyslipidemia, hypertension, altered coagulation, fibrinolysis, obesity, and resistance are the major causes in type 2 diabetes. Let's look at dyslipidemia. Now I want to show just one slide that looks at the reduction in the atheroma volume versus the low density lipoprotein. Now, if we want to reduce the atheroma volume at this stage is about 0.8%, we need to lower our LDL to about 60 milligram per deciliter. There are a lot of studies now that shows that the lower LDL that we use, the better are going to be our results. So for dyslipidemia, can we say that we should be aiming for less than 60 milligram per deciliter versus the present recommendation of 100 milligram per deciliter? We might want to move to look at hypertension. Many studies been done shows that the more intensive blood pressure control that we have, the better is the outcome for stroke, for heart failure, for myocardial infarction, for cardiovascular death. The next slide shows the study, the SPRINT trials, looking at the intensive therapy, maintaining blood pressure, systolic blood pressure of less than 120 versus the standard therapy of less than 140. And we see that in this result, there is about 30% risk reduction. So we want to question ourselves, should we lower our target for blood pressure instead of 140 to perhaps less 120 for those people who are able to do that? So associated risk factors perhaps is not optimally treated, then we might need to consider lowering the targets. The next issue that we might want to discuss to know why there is this Access still high residual risk is to see whether we've been treating our diabetes early enough. As you are familiar, this is the natural progression of diabetes. If we look at the microvascular complication, we see that most time it occurs at about the time that we diagnose type 2 diabetes. But looking at the macrovascular complication, it occurs way early on, perhaps 10 years before we diagnose our diabetes. At the stage when it was still the IFG or IGT level. In the DCOT study, for example, we have shown that IGT is not something that is harmless. IGT increases mortality risk. So the issue that we need to decide is that should we treat the hyperglycemia early, even at the IGT or the IFG stage? We might want to consider that our glycemic control target is still high. And here is the recommended HbA1c level, the ADA wanting us to do 7 or less. The ACC/AASD wants to make it a bit better at 6.5 or less. But then when we look at the evidence, for example, the microangiopathy, this time looking at retinopathy, we see that the prevalence of retinopathy starts increasing when the HbA1c is just about less than 6. Similarly, we have the evidence to show that mortality risk with increasing HbA1c for cardiovascular disease or ischemic heart disease. And the level when it starts increasing is just about 5 point or so, or less than 6. So, question that we might want to ask is that, should then we lower HbA1c target, perhaps now less than 6.0? But perhaps we should also aim at this time for a cure in type 2 diabetes. We call it remission. So, ending my talk with a good news. Type 2 diabetes remission is now possible with weight loss. We can have weight loss and have diabetes remission with bariatric surgery. We can have a remission of about 60 to 80%, or down to about 40% if we follow it long enough. We can have remission by reducing calorie intake. This is a direct trial that shows that people who lose more than 15%, 15 kilogram, can expect 80 over percent remission in the diabetes. We might also want to reduce the HbA1c to less than 6 by using drug combination. Tazolidinedione, metformin, and the SGLT2, GLP-1 receptor agonist. And lately, we've been shown with the good results from this twin creatine therapy And we could see that with the twin keratin therapy, we can expect a weight loss of about 20%. We need to stop now, and perhaps I will just summarize some of the points that we make. First point that we made was that type 2 diabetes caused by insulin defects in insulin production, leading to reduced insulin secretion, beta cell toxicity, and insulin resistance occurring in the liver, brain, adipose tissue, gut, kidneys, liver, and the muscle. In 2022, we are asked to start with lifestyle adjustment and metformin at diagnosis. And lifestyle adjustment will also now include stopping smoking, reducing weight, reducing stress, and having a restful sleep. If that is not good enough, it's not to target yet in terms of our diabetes control, then we might add in additional treatment based on the predominant pathophysiological defect in our type 2 patient. For those are insulin deficient, we might want to choose drug that can increase insulin production or protect the beta cell toxicity. For those with insulin resistant predominantly, then we need to use drug that can reduce insulin resistance, including metformin, tazarotene, GLP-1 receptor agonist. In patients who are at risk of established chronic cardiovascular disease or diabetes, kidney disease, irrespective of their HbA1c level, we will need to treat them appropriately. Those with high risk of or have established cardiovascular disease or risk of congestive cardiac failure, then we want to use SGLT2I. Those are at risk of ischemic heart disease, stroke, the SGLT1 receptor agonist, and those with chronic kidney disease, then with SGLT2I or GLP-1 receptor agonist. But we also take note that in spite of the advances that we make, there is also still the residual risk of cardiovascular disease, which is still very high in the range of about 70 to 80%. And we suggest that perhaps a more aggressive approach may be necessary to lower our blood pressure target, to lower our lipid target, to start treatment for blood sugar rise very early on, even at the stage of IGT or IFG, and to target lower HbA1c level. And lastly, we say that in selected cases, patients who are obese, overweight, diabetes remission should now be a target. And that could be achieved with low-calorie diet, GLP-1 receptor agonist, or the twin keratin that we talked about just now with GLP-1, GIP receptor agonist, or with bariatric surgery. Well, thank you very much for your attention. Cheers.
Thank you, Professor Mustafa, for the excellent lecture. At this point, Diabetes Philippines would like to award the Certificate of Appreciation to Professor Embong Mustafa, for sharing his time and expertise with us. Thank you very much, and we hope to see you soon.